Okay. Last week's quiz. Everybody turn their cameras back on, please. Okay. So last week's quiz was about the antepartum, basically. And one question was about what constitutes high risk. In other words, why would we diagnose a client with high risk initially at the beginning of a pregnancy? So high blood pressure, chronic diseases, adolescent age, obesity, history of multiple pregnancy losses, those kinds of things, okay? Another one is what's important, what's the most, I don't want to say the most important, but a very critical nutritional component for early pregnancy to help prevent neural tube defects. Do you remember what vitamin B9 is?
It's folic acid.
Who remembers what that is?
It's folic acid.
Folic acid, yeah, you need to know that. So if you don't think you got that right on the quiz, then look back again at folic acid, okay? Probable signs of pregnancy. Those are the things that as a nurse or as a provider, you would observe, things that are measurable or at least visual that you would be able to observe if you told your client that they were probably pregnant. Okay. So a bluish coloration of the vaginal tissue and the cervix. What do we call that?
Chadwick.
Chadwick's. And then what's Goodell's sign?
Is it the softening of the cervix?
Yes, yes. And then also we would see things such as a positive urine pregnancy test, the HCG test, either in the blood or the urine. Okay. What else what might we notice during pregnancy? And we're assuming, or we're telling her she's probably pregnant. What else? Can you think of any other ones?
Probable signs. Hager sign.
Hagar sign, yeah. Hagar sign, allotment. So quickening is a presumptive sign, okay? So quickening is not part of that class. Okay, implantation takes place between 7 and 10 days. Okay, it's about a week after fertilization. So to prevent any legal negligence, negligence is a legal term, make sure you're following the policies of the facility where you work. Okay, make sure you are practicing in a way that's prudent. In other words, you are upholding the standards of a nurse. BMI, how do we measure obesity? What BMI?
Don't you divide the weight by the height squared?
Yes. So what is considered an obesity BMI? Where does it start?
Does it start at 25?
30. Hannah said it, but she was muted, but I saw her lips move. Yeah, no, it starts at 30. At 30 BMI, that is obese. Okay. So overweight starts at 25. 25 to 29.99. Okay, and then underweight is 18 and below.
Is this in general or is it just only in pregnancy or pregnant
It's
women?
in general. It's across the board. I'm lagging. Let's see here. Stop that. My computer is acting up. Okay, let's see here. All right, and then you had an estimated due date. So somebody tell me the formula for Nagel's rule.
Subtract 3 months, then add 7 days.
Yes,
And add a year?
and add a year. Go back 3 months, add 7 days, and then add a year. Good. All right. So that was, wait a minute, let's see, your math question. It was 300 micrograms. 300 micrograms in 10 ml. So that means 30 micrograms in 1 ml. So we needed 30 micrograms for the COVID vaccine dose. So we only need 1 ml. So one question was about culture. If you have an ethnocentric nurse, she is not going to address the cultural needs of a client. So cultural relativism is a term that we use that just if a nurse is practicing cultural sensitivity, she's also practicing relativism. In other words, she is relating the client culture in the current environment. So if she's in labor and delivery, if she's in labor, are we putting her cultural needs as part of the care plan? Are we considering those? Are we asking our client? That's being culturally relevant. So that was the answer to that one question. Okay, so cultural relativism is just applying what you know about your client in the care plan. Okay, what you're doing for her that she wants to do during labor. All right. Now, let's put that down. So I know did you feel lost with quiz 2, or did you feel like you were reading enough and preparing enough? How did you feel? What are you feeling right now? Just start talking.
Overwhelmed.
Yeah,
Overwhelmed.
I think the one question that confused me was the one, it was like it was 2 answers and one of them was correct and one of them was wrong. It was about the blood test. And it was saying like, I know you talked about, Down syndrome and all of that, but the other one was just saying like, oh, it tests for genetics and this. Another one was talking about, oh, it tests for Down syndrome and this. And I'm like, well, this mentions it. So I thought that might have been the right answer. I don't know if I got it right or wrong, but then the other one just came kind of like it was just really bland. So I think that was a little confusing.
That was a little challenging for you. So what is carrier screening?
So from my understanding, carrier screening is when you test to see if the person has the chance of giving their child like a genetic disorder or something, I guess, with both parents or not trying to
Very
explain.
good. Yeah, that's exactly right, Janae. That's exactly right. You're seeing if your client has one of those abnormal genes. Okay, so in OB, we're talking mainly about, at least for this class, about the recessive genes. Okay, so both parents have to have it, both pairs. Okay, So genes for cystic fibrosis and sickle cell in particular, if both parents have that, does it have those genes, even if they don't have the disease, if they carry the gene for the disease, 1 out of every 4 children is at risk for actually receiving both genes, mother and father, and then having the disorder or the defect in the
So it's more
disease.
like recessive and like dominant. It has nothing to do with like the Down syndrome.
No, so when we're talking about chromosomal disorders, we're talking more of the AFP, the maternal markers, AFP, HCG, inhibin, and estrogen. Those are 4 markers that can be found with the maternal serum screening. Okay, but both of these are blood tests. Okay. Okay, we can do the carrier screening anytime in a person's life. We could draw blood for each and every one of you right now. I could do carrier screening on Jay. Okay, I could do carrier screening on Rayford. It would tell us if he carries the cystic fibrosis gene. It would tell us any gene we're looking for. Okay, so it's not just part of OB, it's everywhere. But the MS-AFP, the maternal serum, is specific for pregnancy because there's a baby in there, and that's where we're getting the information, okay? And that's about chromosomal abnormalities or neural tube defects, Down syndrome, trisomies, all those kinds of things, okay? That's the difference between the two. I know it can be very confusing. So usually the MS-AFP we do after week 11 of the pregnancy. It's too early to do it any earlier. It's too late to do it after the 20th week. So between week 11 and 20 is the most ideal time to do the MS-AFP. That's the difference between the two. Okay. If you're feeling overwhelmed, that's not uncommon at week 3. It's not uncommon. That's why we give you as much stuff, and I do apologize for you not having access to the documents earlier. It's the way I saved them on my computer. I saved them from an online resource, and you don't have access to that. So they should be fixed now. So you do have them, and they're really good. Those PowerPoints and documents I gave you will really help you. So like I have said, use them as you look at the book and study. So hopefully what we go through today will also help you, okay, with this new content. And we could pull in some of the old content from last week. So if you have questions or if they come up during our discussion today, ask me about last week. We're not just putting it behind us, we're carrying it with us. And that's why I like to do the case studies. So let's start with the case study. Let's see here, birth, PowerPoint. Okay, so we share the screen. So we have a client who's 40 years old. She's a prima gravida. And what does prima gravida mean?
First time pregnancy.
First time pregnant, first pregnancy. Let me move this over and make it bigger. There we go. First time pregnancies. So she comes to labor unit. She comes to the hospital. She's 39 weeks pregnant. She thinks her water has broken and she thinks she might be in labor. She is planning a medication-free birth. So what are some things that come to your mind? She thinks her water is broken. Did anybody have any opportunity to be prepared for today? Everybody's kind of quiet. Okay, let's just get through it then. Okay, so one thing you might consider, how does she know her water? How do we know the water is broken? How do you know that's what she's leaking and it's not urine? How do we determine that she's in labor? What concerns do you have? This is her first pregnancy, her first labor, and she wants a medication-free birth. What are some things you're thinking about? But the first thing that comes to my mind is, well, yeah, I do respect that, but I do want you to know that there are free options, not free, there are risk-free options for you to choose that are healthy for you and your baby so you can manage your discomfort. So our clients have the right to know, what they, I don't know why this is, bring it down a little bit. Why is this showing like that? Okay. So the things that the nurse documents in the patient's chart, in the prenatal record and initial assessments. Okay. When you have a client that comes to the hospital, they're in labor, we quickly access the prenatal record, the record from her visits during the antepartum. So we have her history, her physical from the antepartum. We have all her blood tests. We know all that information. So when she comes in, her blood pressure is 134/80. Her heart rate is 84. Respirations are 20. O2 sat is 97. She's had 2 in vitro fertilizations to try to get pregnant. So apparently she's had some difficulty getting pregnant. She's 40 years old. So she's at risk for having a baby with Down syndrome. So we quickly want to look in the chart to see what her MSAFP result was, okay? She said she's been leaking fluid since the morning. And then her contractions started right after that, okay? Oops, I'm gonna erase my and word here. Okay, so one of the first things we do is apply an external fetal monitoring transducer and ultrasound, okay? We find that our baby has got a heart rate of 155 beats a minute. Is that normal?
Yes.
Yes. So anything less than 160 and over 110 is normal. Okay, 110 to 160 is normal. And moderate variability, early decelerations. These are all normal. Okay, we want to see changes in the baby's heart rate. We want to see the baby's heart rate going up and down in that range. Okay. And early decelerations, to decelerate means to slow down, right? So early heart rate decelerations are common in pregnancy during a contraction when the head is being compressed, okay? She does have a history of group beta strep, which is a enterococci, that bacteria found in urine and vaginal tissue. Okay, so since she has a history, we're going to treat her with penicillin during pregnancy. Okay, she has a family history of difficulty during labor dystocia. Okay, so we need to think about that for her. Her cervix is dilated at 3 centimeters. Effaced at 60 percent, 3 centimeters dilated, effaced at 60%, and the baby is at station -1. So -1 means it's above the 0 mark. The baby's not quite engaged, okay? You cannot palpate any contractions yet. Okay, her fundal weight is estimated at 3,500 grams. That's a large baby, but not too bad. Okay, but that might give us an indication of why maybe a family member had trouble. They had a large baby. Okay, and then our Leopold maneuvers we applied. We did our maneuvers. And the baby is in the vertex presentation. In other words, the baby is head down. That's perfect. The baby is flexed. That's good. Left occiput posterior, we're going to learn about. It's not as beneficial, but it's still very doable. Okay.
I have a question.
Yes.
The Leopold, is that it was like checking the position of the baby?
Yeah. Yes.
Okay.
So Janae, you'd put your hands on mom's belly and you would be able to feel, is it the head at the bottom or the butt? There's a certain way of doing it. Where's the spine? And that tells us the position of the baby, whether baby is posterior or anterior. Okay. And her blood type is O negative. So what will she need if baby's cord blood is positive? What will she need?
Rogam.
Rogam. So within 72 hours after the baby's delivered, she needs to have that Rogam injected. Okay.
That's
But if
only
baby's blood type is negative, then we don't need to give Rogam. Okay. So I don't know why these are like this. Tell you what, I have had more computer issues. Okay. So these are lists, and I apologize. Just there we go. That's better. All right. So this is a common, or I should say, this is an NGN style question where you kind of fill in the blanks. Okay. So we're going to do this together. The first one here, this is option 1 in this list right here that I'm trying to pull down. Here it is. All right. The nurse reports findings to the provider. The client's vaginal fluid is assessed with a blank test for pH. So is it an acid test, a lab test, a culture, or an amniocentesis?
Acid test.
Acid test. What in particular, what do we use to test the acidity of the fluid? Do you remember?
I thought you checked for like the amniotic fluid.
Okay.
Is that what it is?
Yeah,
Of
you're
how much
checking for the
alkaline it is?
Yes. So we can test the vaginal fluid that the client has told us she's been having. We need to check the acidity of it. We can use a nitrazine strip. Okay. It's a litmus test almost. It's a test of pH. So if the fluid is very acidic, it's urine. Okay. So our nitrazine test would be more of an orange color. If we took that strip and put it in the vaginal fluid and it became very green or blue-green or blue, it's very alkaline. It's the opposite. Okay. So blue means it's amniotic fluid. Okay. So we're going to check that on our client. Okay. So we know now that yes, she's been leaking fluid. Okay. We would also see what if we looked at the fluid underneath a microscope. It's what happens to amniotic fluid when you look at it underneath the microscope, what you would see. Well, it's just ferning. You see this fern up here, this flower on top of the slide. You'd see like a ferning. It looks like an actual fern. Okay, it's in that shape. Okay, it's called ferning. Okay, so the client is admitted and scheduled for a C-section. I'm sorry. The client is admitted and scheduled for what? It's not a C-section. What is she scheduled for? I told you she was in labor though, didn't I? That was my mistake.
Would it be an induction?
Induction, yeah. If she's not in labor, we would definitely want to induce her into labor since she's leaking amniotic fluid. Okay. All right. So the provider notes that the client has a history of group beta strep bacteria and orders what? What medication do we give for this kind of bacteria?
Penicillin.
Penicillin. Pretty standard with group beta strep clients who carry it. If we know they carry it, we treat during labor and delivery. Okay. So we've ordered some penicillin. The nurse points out to the provider that the client is Rh negative, so she will need
A Rogaine.
Rogaine. Yeah, Rogaine. Okay. All right. So what medication do we use to induce labor? You had all those medication lists that I gave you. Which one of those starts contractions?
Oxytocin.
Oxytocin. So who can tell me about oxytocin? What kind of a drug is it?
It's a hormone. It's a
It's
pituitary.
a hormone. Go ahead. You have more?
I was just saying it's a pituitary hormone.
Right, you're right. It's so pituitary hormones. There's a stimulating hormone, the FSH hormones that come from the pituitary stimulate the production of progesterone and oxytocin and estrogen. Okay, all of those. So all three of those are hormones, but oxytocin is the one that causes contractions. So if a woman goes into labor on her own, that means oxytocin has been released, okay, from her posterior pituitary. Okay, and it starts contractions, uterine contractions. It's a high risk drug, okay? We can give too much. Okay, so 4 hours after the induction, the client is having regular contractions every 4 to 5 minutes, lasting 60 seconds, which is normal. Okay, the nurse is reassured by the fetal heart pattern she sees on the monitor. What does she observe? Pattern A, pattern B, or pattern C?
Okay, don't walk through.
Taylor, what do you think? Which one do you think is the right group? Anybody?
Pattern A.
The A.
Yeah, pattern A, because there's moderate variability. Early deceleration is fine. Heart rate is good. In pattern B, the heart rate is fine, but late decelerations and minimal variability are not good. Pattern C, none of it is good. Okay, so that's not, we call pattern A reassuring. Okay, patterns B and C are non-reassuring. In other words, something is not right with the fetus. Okay. So labor continues, and the client is now 4 centimeters dilated, 70% effaced, and the baby is at the 0th station. So baby is engaged at 4 centimeters, means she's in active labor. Contractions are becoming uncomfortable for her, okay? But the client is doing well with a doula. Okay, you might know what a doula is.
It's like a midwife.
It's like a, well, it's not a clinician at all.
Mm-mm.
They are a layperson in a way that they don't have any kind of medical degree. They are like a coach. They are trained though. A doula helps with pain management, helps with breathing exercises, positioning. Okay, so that's what a doula is. So below, we're going to mark the teaching that's indicated. Okay, and then what's contraindicated in this list and what's just non-essential. Okay, so upright positions, including walking, can help with labor. Is that a good thing? Contraindicated or non-essential?
Indicated.
Yeah, it's indicated. Walking and position changes enhance circulation. Okay, it enhances circulation. It also helps gravity to assist labor. Okay. It looks like you are in a lot of pain. I am going to call anesthesia. Is that a good thing to say to your client?
No,
Contraindicated.
Why?
Because you don't want to push anesthesia on them if they're wanting a natural birth.
Right. You could say it looks like you're in a lot of pain. Do you want anything? Do you want some medication? You certainly want to verify or at least clarify to make sure she's doing okay. Yeah. Your baby's heart rate is not reassuring, so I need to call the provider. Is that indicated, contraindicated, or non-essential? What do you think?
I'd say contraindicated.
So what would you do if you saw something that was non-reassuring on the heart monitor on the fetus?
I'd have, if there was another nurse available in the room, have them notify the PCP or HCP.
Okay. Okay. I think you can phrase it a little differently. Your baby's heart rate's dropping a little bit. I think I'm going to call the provider. Let's get you rolled over on your left side and here. Let's get some oxygen on you. We're going to ask your provider to come check you out. Okay. So just to use the word non-reassuring, I don't think I would say that. So I would say that it's contraindicated as well, because you need to say it in a different way. Your labor will be longer because of your age.
it's non-essential.
That's not essential. It might be true, but it's certainly not something you want to say.
Very generalized.
Yeah. You may have some clear fluids to stay hydrated. Rachel is nodding her head, and I agree. Yes. Unless the provider has decided if she's really having a lot of trouble to keep her NPO in case we have to do a C-section. Okay. But usually clear liquids are okay. So we have another tool. We have a tool we use to evaluate the condition of the cervix. And we'll be talking about all these things today. Okay, so the client's cervix is soft. It's anterior, 8 centimeters dilated, and 100% effaced. And it's the baby's head is pressing against the perineum. What's her Bishop score? Now, if you didn't even know anything about this, you could still come up with the Bishop score, right? Client cervix is soft, so that would be a 2. Anterior would be another 2. Hunter said 100% effaced, so that would be a 3. So we're at a 7 already, and it's pressing against the 8 centimeters. We're at 10. Okay, so this is good. 2, 4, 7, and 10. Okay, and we don't have the information on the station. So she's a Bishop score of 10. And that's very promising for a very effective labor pattern. Okay. So that's what we do, how we do a Bishop score. How is the condition of the cervix and the position of the cervix? A lot of times we'll use a Bishop score when we're assessing a client for induction. Okay, which we'll talk about another week. Okay, so as she becomes more dilated and a lot more pressure in the pelvis, the client lashes out at the nurse. She said, "It hurts so much. I can't do this. Get somebody in here who knows what to do." So she's mad at everybody in the room, and now she's almost panicking because she's really being overwhelmed with pain. How would you respond? How would you answer that statement your client makes? See, I'm going to call on somebody. Tracy, how would you respond to your client if she says that to you? Get somebody in here who knows what to do.
Well, first I tried to explain to her there's many options to alleviate the pain and see what I could do to offer her help there so that we can
Okay.
get her calmed down.
Okay. So you can
I
just say,
kind of
well,
before to get someone else in their part and just kind of try to help her through.
yeah, that's true.
I'm here for
You
you.
can help her turn position.
I'd
Okay.
probably encourage, try and bring her back to what I would say, focus, refocus, and maybe use something that is like a distractor so that she kind of can calm down by coming back to center.
Yeah, you could instruct her on some deep breathing exercises or some ant blows exercises. If she didn't go to childbirth classes and I imagine that somebody wanted to do it naturally, she would want to go to childbirth classes. So you might have to help her refocus. And then you can ask her then if you want me to call anesthesia or do you want something in your IV? She needs to have the options. Okay. So she's at 8 centimeters dilated and she's completely effaced. So she's in what we call the transition phase. She's getting ready, usually within an hour or two, to actually deliver the baby. Depends how quickly the baby descends. Okay. So what are her options at this point as far as pain goes? Can we do an epidural this late?
No.
Most of her pain at 8 centimeter dilation and complete effacement is in the perineum, the cervix, the vagina, and the pelvic floor. It's not in her abdomen so much anymore. Okay.
So you give
So
a nerve block?
yeah, a pudendal nerve block would be much more appropriate. Okay. What's wrong with opioid injections this late?
Affect the baby.
In
Decrease
what way?
Respirations, respiratory rate.
Okay, yeah. So opioid is a central nervous system depressant. Okay, so it's going to affect mothers as well, but it also passes through the placenta and it depresses fetal respirations. Even though they're not breathing like we breathe, it depresses the central nervous system of the fetus, such as when they're born, their respiratory effort might not be as exaggerated. Okay, they might be a little more lethargic at birth, and we don't want that. So it's contraindicated that late in pregnancy. So
I do-
they're only,
I did have a question about the prenatal block. So what would be the ranges? Because you know, like you get the epidural, if it's too late, what are the too late ranges? Is it like 8 to 10, 7 to 10?
yeah, usually 8 by 8 centimeters, epidurals are not going to be effective to begin with. Okay. They will a little bit, but not as much as a pudendal block. And so she was able to deliver a baby, no problem. Okay. So I brought up a lot of new concepts for you, didn't I? A lot of new stuff. You're thinking, my gosh, what's she talking about? I never heard that before. Even if you've had 3 or 4 children, you never heard that before. If you've never taken an OB class, even if you've had babies, you're going to learn a lot more than what you realize. You're going to learn more than what you're going to realize you didn't know much. Okay, having that baby. Okay. Let's see. Let's do a little review. Okay. Some of it's new, some of it's not so new. All right. So this is matching. So we've got A, B, C, D, F, all the way through N, and then we got all these things on the side here. So non-stress test. What is a non-stress test? Which one of these A through N describes or sounds like a non-stress test, or the purpose of doing a non-stress test? Do you remember the non-stress test? We apply a monitor to mom and she lets us know when the baby moves. And then we look at the monitor. Did the heart rate go up over a 15-second period? 15 beats a minute. Which one does that, what does it tell us when a baby's heart rate goes up during movement?
Is it A?
Is it D?
No.
No, is it E? Action for this.
Nope.
Is it the acceleration?
No, there's no accelerations there.
This is confusing. I'm confused.
Okay, so the non-stress tells us that the fetus has adequate oxygenation. Okay, the fetus has adequate oxygenation. Okay, cardiac output increases in pregnancy. What can you connect that with? You're muted if you're talking. You wanted to be muted. It's
I was
oxygen.
thinking it's like yeah, that one. It's oxygen demand.
Yeah, and this one is this one. Okay. Plasma volume increases more than RBC volume. Which one is that?
That's that physiologic anemia.
Yeah.
You go. girl.
Maternal hypotension and fetal decelerations.
Is that the syndrome? Supine hypotension.
Tension.
Yes. Knee chest positioning. This one you might not know.
Uteroplacental insufficient.
Yeah, when we reposition mother, we're doing it to improve oxygenation of the fetus, increase blood flow. Action for decelerations could be the same thing. Okay, knee chest positions. So what other action can we do if we see the baby's heart rate drop?
Lateral position.
Yeah, yeah. So repositioning mother is the number one priority for any heart rate dropping, any deceleration. Facilitating the or inhibiting the process of labor.
Progesterone.
Nope.
Five P's.
The 5 P's of labor. Yep. Intrauterine growth restriction.
Progesterone.
I'm trying to remember which one it is. It would probably be more of in decreased blood flow to the uterus. I don't think I had a good answer for that one. Okay, what about -3 + 7 + 1?
Nagels.
Yeah. Builds the endometrium, relaxes the uterus, may cause low back pain. Yeah, I see your lips moving, JP. Autosomal recessive was going to be your sickle cell or cystic fibrosis. Cervical dilation and effacement.
5 P's.
5 P's, yes. Inadequate blood flow to the uterus and placenta is going to be this one again. Chadwick, Goodell, Hagar, and positive G. Okay. But why don't we take a break for a few minutes? Let's meet back at 4:30. 10 minutes. No, 4:25. 25 after the hour. We'll meet back. Okay. I've got the Canvas open again. I wanted to show you something in the announcements in case you haven't noticed it. But the week 2, I pulled up here. Welcome to week 2 announcement. And this is what I'm going to do every week, is at the very bottom is the recording from last week. If it's not from this class, it's from another class. Okay, so you'll get a recording of the previous week. Every week you'll get a recording that you can watch in case you want to see part of what we talked about again today. Okay, I wanted to show you that too. And here's another video you can watch. This is doing a case study with a group of students from last quarter, which we'll probably do for our review session Sunday. Okay. So the exam is next week, and I'm going to post some exam instructions for you, but we're going to do our exams the same way we do our quizzes. At the beginning of the class, we'll get all set up, and we have to sign everybody in. I have to look at everybody. I have to see your ID badge. I want to see your computer, your desktop. And I want to see, make sure you don't have any Apple Watch on or any other kind of smartwatch, no earbuds, okay? No one else in the room, a quiet environment, a reliable internet connection, and 2 devices. Okay, you need your computer for ExamSoft or Examplify. You'll need a second device to get onto Zoom so we can use it as a camera, okay, to record the session. Okay, so you can use an iPad as your second device, or you can use another computer, you can use your phone. However, you can get onto Zoom and be present during the exam time. Okay, because when you're on ExamSoft taking exams, you can't get on the internet for anything else. It blocks all the other websites. So you need a second device. All right. If you plan to take the exam on campus with a proctor, you need to let me know by Thursday. Okay, Thursday of this week. Taking your exam on campus with a proctor who you have to find one. I'm not going to do that for you. Find someone who will be with you while you take your exam and proctor you. And you need to let me know. You need to take the exam on the same day that the rest of the class is taking the exam. Now, it can be earlier in the day if you want to do that. And if that's true, then you still have to come back to class at about 4:15, okay, and be on Zoom. All right.
So we can go take
If-
it on campus if we want to use double devices. We don't have to worry about having somebody stand there and proctor us, right?
If you want to just be on campus for the internet capability,
Mm-hmm.
then you do need a second device. If you
Right,
don't have anybody to proctor. Yes.
Right. We don't have to be
Yeah.
on there proctoring us. Okay.
Right,
If
right.
if we're doing it on the second device. Okay.
Yeah. If you go to campus because you don't want to be on Zoom, you want to be proctored by somebody, you don't need the second device. You can
Gotcha.
go to campus, ask someone to proctor you during your exam, and you don't have to be on Zoom during that time, but you still need to come to class. Okay, later when you're done the exam, you need to be on class at 4:15. Okay. Does that make sense, or is that clear as mud? If you don't have a very reliable internet, and I don't think anybody in this class has that issue, because right
No,
now
I'm
you
on it primarily for the non-disruptions in the house of
oh
six.
non-distraction disruptions is good. Yeah, you don't want a bunch of people around when you're trying to take an exam. Okay. All right. Let's talk about labor and birth. Okay, so assessment. So we've got 2 clients to take care of. We have to assess mother. We're there as an advocate. We're there as an educator, helping her to be the most comfortable she can possibly be during labor, and help her with different strategies for comfort, different positioning, different therapies that we can do during labor. We also have to watch the baby. Now, there was a time when we didn't do continuous fetal monitoring. We would just listen to the heartbeat every once in a while, intermittent assessment of the fetus. Nowadays, we're on the monitor. We have her on the monitor, and we can see the fetal heart rate at all times. So that's the difference between the two. So when we're monitoring, we have a monitor for contractions and a monitor for the heart rate. So there's 2 devices on mom's belly, as you can see in that bottom picture. On the right is another video, and I don't think it's the same one I gave you separately, about spinal epidurals. So some of the pain management things we'll talk about today too. So what is labor? How does it begin? Well, it begins by the release of prostaglandins and oxytocin. We can't predict exactly when labor begins. We don't know exactly how it begins, but we know that oxytocin levels are higher, and so are the prostaglandin levels. Those are two natural hormones in the body, but we can also give them as medications or exogenously, okay? So what we identify as labor are contractions and cervical changes. So the purpose of a contraction is to open up the cervix, to dilate it and to thin it out. And we call that effacement. So if you look at this picture, at the top, you can see the cervix in the very first picture of the baby. The cervix is closed and is thick, okay? The next picture shows it fully effaced. It's very thin, it's hardly recognizable, but it's still closed. The next picture shows it 5 centimeters dilated. And the last one shows it fully dilated. So fully dilated and fully effaced means that when I do an exam, a vaginal exam to locate the cervix, I'm not going to find it. Okay, I'm not going to be able to palpate the cervix when it's fully dilated and thinned out. It's completely lost, okay? Because what occurs during labor are contractions that usually start at one side of the uterus. So we know that the top of the uterus is the fundus. And so the contraction of the muscle begins one side or the other, and it spreads through the top of the uterus. And then it makes its way down so that what it's doing, it's pulling up on the uterine muscle in its entirety to try to open up that cervix, okay? There's a really good video that we're going to watch to help understand this even better. Okay, so a contraction, the strength of the contraction is in the top of the muscle, okay, the fundus, and then it begins to fade. Okay. Some signs, like in our client, she might experience things that indicate labor is starting, or it's imminently starting. Okay, lightning, Braxton Hicks, increased vaginal mucus. The cervix is softening. She feels a surge of energy, also called nesting, and a bloody show. Possibly the rupture of membranes, like our client. So if we have a client that calls the office and says that she's leaking fluid, we need to determine if it's amniotic fluid or amniotic fluid or urine. So we can use our nitrazine strips and we can test the fluid. So amniotic fluid is very alkaline. So it's the opposite of urine. Urine is very acidic, so it's going to be at more of an orange color. And then the dark bluish, maybe a little green in it, is alkaline fluid, 7.5 pH versus a 4.5 pH. And that way we know that she indeed is leaking urine. And to remember what we would see under a microscope, if we put some amniotic fluid under a microscope and looked at it.
The ferny.
Burn looking.
Yeah, the ferning. Yeah, I don't have a picture of that, but a ferning. So lightning, if you can remember lightning, because lightning drops out of the sky, right? So lightning is when the baby actually drops down and begins to engage in the pelvis, okay? For a prima para, this can happen 3 weeks before she goes into labor. For a multipara or a multigravida, it usually occurs right before she goes into labor. Okay, Braxton Hicks contractions are fake contractions. Okay, it's like practice contractions, and they're usually felt on the sides of the abdomen, and it's a tightening of the whole abdomen. But the strength is from the side, so it's not like a normal contraction that begins slowly and rises and strengthens to an epitome and then slowly fades. Braxton Hicks are more of a tightening, and they're irregular. Okay. Sometimes there's a term, losing the mucus plug. I've lost my plug, I'm going into labor. That's a layman's term, but yes, she'll notice an increase in vaginal mucus. The cervix does begin to soften. It even might to dilate and efface, and it does usually before she actually goes into labor. Okay, surge of energy. She's going to want to get ready for the baby. She want to do some last minute shopping for diapers or whatever she needs. She might have some bloody show. There might be some blood mixed with vaginal mucus, and then the rupture of the membranes. So those are some signs and symptoms preceding labor. So the 5 P's of labor we talked about. These are factors that can affect how labor progresses. Does it slow labor down? Does it inhibit labor? Or does it help labor progress more rapidly? Now, we don't want a labor that starts and ends within 3 hours. That's called a precipitous labor. There's risk factors associated with precipitous labor. Uterine rupture, cervical rupture, postpartum hemorrhage, things like that. Very serious. So we don't want a precipitous labor. So there are 5 P's. So the first P is the passenger, which is a fetus, right, in the placenta. The second P is the passageway, mother's anatomy. Okay, and then the powers of labor, the primary power of labor are the contractions. Okay, the contraction cause cervical dilation and effacement. The secondary power is at the end, right before the baby's born, when mother begins to bear down and push. Another factor that can help or hinder labor is mother's position. Is she lying flat on her bed the whole time? Is she up walking around? It's recommended that we help her to change position to enhance labor, but changing position also increases circulation. It also might increase comfort. It's a distractor. Help her relax more between contractions. Okay, so it's important that we encourage her to try different positions during labor. And then the last P is the psychologic response of mother or her psyche. Is she anxious? What's her mental state? What's her emotional state? Okay, is she able to relax between contractions and take a quick nap? Women often do. It's very exhausting to go through labor. So if her contractions are 3 minutes, she'll fall asleep right away and sleep and wake up till when the next contraction starts. So helping her work through her contractions using different therapies, deep breathing initially, and as the pain increases, helping to do more of a pant puff, pant blow, plant blow. So he, and then giving her a place in the room to focus on her breathing. Okay. If she becomes anxious and overwhelmed with pain, we need to always offer some kind of pain medication. Okay. If she told you at the beginning that she didn't want any pain medication, then we need to respect that. But if she comes to the point of feeling overwhelmed, she seems overwhelmed, you need to address it. You need to say, you seem to be overwhelmed. Would you like some pain medication? Okay. We don't want her to be overwhelmed and feeling very anxious about labor and delivery. the higher her anxiety, the less the uterus can relax between contractions, and the contractions aren't as effective when she's anxious. Okay, so it inhibits the good blood flow to the placenta. Okay, so also consider the cultural responses. What does a woman need to help her with pain? Truly, does she need her whole family there, or does she just want one person? So make sure you're always addressing the cultural and spiritual aspects of her labor. So those
So
are
do
the
they
5
have like
Ps.
a standing order for those pain meds, even if the patient has said, I want all natural? Do they have that standing order so that if they do get overwhelmed and they said, never mind, I don't want natural, I need something?
It depends on the facility, but usually yes. Usually yes. Um, certainly standing order. But I think for anesthesia, there might be a standing order to contact anesthesia based on client's desire. Okay, but for an epidural, certainly, and I think clients need to be educated during the antepartum about pain management. You know, closer towards the end about what the options are as far as what are epidurals, and make them aware of them prior to going into labor. So the 5 Ps, you just have to memorize them, but you do need to know them, okay? So what other things affect labor besides, so this is part of the 5 Ps. When we're thinking about the passenger and the positioning, we were talking about the passenger, the lie of the baby. Is the baby cephalic with the head down? Or is the baby in a breech presentation with the butt down or the feet down? Or maybe oblique, like a diagonal lie, transverse lie. So these are different kinds of lie. So it's the relationship of the baby with the floor, okay? And then the attitude of the fetus is another factor. Attitude means flexed or extended. Flexed or extended. And you don't have to memorize all these different attitudes, but know that the vertex flexed is the most ideal. Baby in a flexed position can navigate through the birth canal rather easily, okay? But an extended or brow or face presentation, which would be an extended. Sinciput is a military, just straight on, okay? Those are more difficult to navigate. It can be done, of course, but the vertex flexed is the best position. Okay, so all joints are flexed. The station is another, just where is the baby as far as station goes? 0 station. So the station is the 0 at the 0 mark is the baby's head at the level of the ischial spines. Okay, and then if the baby's up a little bit, like this baby is, -3, as it get closest to 0, -2, -1. So the +1 +2 +3 means the baby is descending below the engagement. So we'll see the descent during the active labor and transition period. Okay, so that's what we mean by fetal station. And then lastly, the fetal position. And this is position in relation to the mother's spine, not the position of the mother, but the position of the baby. So this is based on the back of the baby's head, the occiput, okay, and the mother's spine. Where is the occiput in relation to the mother's vertebral column? Okay, so let's look at this one. Let's see, I think did I do one more? Yes. Okay, so this one here I'm going to make it larger so you can see it. So this is one of the ideal positions. This is called the right occiput posterior. Well, actually, this is not. The anterior is better. This is not. But this is it show, and you can see in this picture, and these pictures are in your book, that the back of the fetal head is against the mother's spine or vertebral column. So it's posterior. Okay. The occiput is posterior. And it's angled toward the mother's right side. Okay. So right occiput posterior. The left occiput posterior, once again, it's against the mother's spine, but it's angled more towards her left side. Okay, and that's the position of the baby. This woman is going to have back labor, we call it. Pain, a lot of pain in her back. And sometimes if we apply counter pressure, it reduces the pain, or repositioning to try to get that baby to turn. And then the other one is the right occiput anterior. So you can see the back of the head where the occiput is facing forward towards the mother's front. So it's towards the right side. Okay. So right occiput anterior or left occiput anterior. So the anterior position is a more comfortable position for mother. Okay. And it does affect labor. So a flex baby in the anterior position is going to be a much more comfortable and easy labor. So those are your 5 P's. So we just got finished talking about the passenger. So the presentation, the size of the head, the size of the baby. Cephalic means that the head is down. Breech means that the butt or the feet are down. Sacrum, where is the fetal lie? How is the baby lying? See, we can have a cephalic baby, but it could be in the sicciput position. Okay, so fetal lie means longitudinal transverse. And then the attitude is the flexion, right? Or the extension of the fetus. And then the position is about the back of the head. Where is the back of the head? Okay. So the primary powers are the contractions, and the contractions are what causes the cervix to dilate. So we can tell if a client is truly in labor if she's having regular contractions that are occurring at a regular frequency, and they are actually effectively dilating the cervix and effacing it. Okay, if she's having contractions, but they're irregular, they might be uncomfortable. But if they're irregular and there's no change in the cervix, then she's not in true labor. It's really important to know that, to know whether to send your client home from the hospital or to keep her. If her contractions aren't regular and they're not effective and she's not dilating, send her home. Okay. So let's say we did do our Leopold maneuvers to see, your client said that she's in labor and she comes in and you want to know for sure what position that baby is in. Is this baby flexed, right, or posterior, attitude, and position, okay? So you determined that your fetus that you're palpating is in the right occiput posterior. Okay, so it's one of these two. Okay, so it's the right occiput posterior, this one, ROP. You did your Leopold and this is what you determined. Okay, you didn't feel the spine on the front or on the sides. So you know your baby's in the posterior position. Okay, so where are you going to listen to, or where would be the best place to auscultate the baby's heart tones? above the umbilicus. So where is the umbilicus here? Okay, on the left side or the right side? Or below the umbilicus? You know where the umbilicus is? The umbilicus is probably right in here. Okay, right in the middle.
C.
So you think it's below the umbilicus and it's on the right side. Correct. That's correct. Wherever you can get to the chest or the back. And then we have stages of labor. Okay, now that we know that our client is in labor, she's having regular contractions every 5 minutes. Okay, and let's say she's dilated at 3 centimeters and she's 50% effaced, or let's say 60% effaced. So her cervix is changing. Okay, it's beginning to open up and thin out because of the contractions. Okay, so stage 1 is technically labor. Okay, stage 2 is delivery. Stage 3 is the placental delivery. Stage 4 is the first 2 hours postpartum. Okay, so stage 1 is when labor occurs, changing that cervix, thinning it out, effacing it, and dilating it and open it up. So stage 1, there's 3 phases, okay? A latent phase, and during the latent phase, she's still at home. She's having regular contractions, and the cervix might be changing, but her contractions are far apart, 15 minutes apart, and she doesn't need to come to the hospital until they're about 10 minutes apart. Okay, so when she reaches that 4th centimeter in dilation, so if she comes into the hospital, her contractions are 10 minutes apart. We do a quick admission assessment. We attach monitors. We begin educating our client, explaining to our client what we're doing. We're going to look at fetal tracing. What's the fetus doing? Is the heart rate good? Are there variability, any decelerations? And then we're going to examine mother to assess the condition of our cervix. So we can feel the contractions. We need to palpate her abdomen to feel the strength of the contraction, although our monitor will tell us the strength of the contraction. Now, you don't have to know about the strength of the contraction. You don't have to know about Montevideo units. Montevideo units is the accumulation of contractions over a 10-minute period. What was the pressure? Okay. But you really don't need to know that. So stage 1 begins with regular uterine contractions. It ends with the cervix being completely dilated, completely phased, and the baby begins to descend, and she's going into stage 2. So the active phase is usually when those contractions are 10 minutes apart. She's dilated 4 to 7 centimeters. Okay, so her contractions are become stronger and it's very active. Okay, so we'd be creative if she's chosen not to receive any medications, some non-pharmacological things that we can do with her. Okay, then she goes into what's called a transition phase. And this is when she reaches 8 centimeters to 10 centimeters at that last little bit. Now, this might last a couple hours. Okay, so transition phase to 8 centimeters to 10 centimeters. She might feel the urge to bear down when she gets close to 10 centimeters. And that's because of what we call a Ferguson reflex. Okay, the Ferguson reflex. Okay, so second stage of labor is delivery. So it begins when she is fully dilated and completely effaced, and it ends when the baby is born. Okay, and it also has 3 phases. There's a latent phase. It's the calm, passive descent of the baby through the canal. So the baby between contraction is beginning to descend more. Okay, and then there's a descent phase when the mother has the Ferguson reflex occurring. And it's an active pushing. So she feels the urge to bear down and push. Okay. And she has some increase in bloody show. Okay. Between contractions, she's going to be relaxed a little bit more. Okay. Now, in the transition phase of delivery, we have the baby's head bearing against or pushing against the pelvic muscles and the perineum, the floor itself. So we have her push only during contractions. So between contractions, she needs to rest. And if she falls asleep, let her sleep, okay? And when she wakes up and a new contraction starting, then you can assist her and coach her in managing her pain, okay? Once that baby is completely delivered, then we're waiting on the placenta to separate and another contraction occur to push the placenta out. Usually during placental expulsion, mother is too caught up with the baby. She doesn't even know what's going on. Okay, well, she might know, but she's more enthralled with that newborn. Okay, so the fundus continues to contract, and then you'll see a dark blood gushing from the vagina because of the placenta. And then of course, the umbilical cord that's attached to it lengthens. Okay, she might feel a sense of fullness and say something. And it's at this point we're more vigilant, because the number one cause of mortality during labor and delivery is the postpartum period, and that's postpartum hemorrhage. Okay, so being very careful, measuring blood loss during labor and delivery, look at vital signs, watch the client, know the signs of hypovolemic shock, hemorrhagic shock. Okay, pay attention to what's going on with the uterus, and so we're more vigilant during this time, during that third stage and entering the postpartum stage. So we want to keep our eye on the uterus. We want it to continue to contract regularly, because that helps shrink that uterus and squeeze those blood vessels that the placenta were attached to.
What was stage 3 referred to as?
It's the delivery of the placenta.
Okay.
Can you see the stages of delivery on the screen?
Yeah, I had stage 1 was labor, stage 2 was delivery, but I missed what you referred to stage 3 as.
It's placental delivery. Okay.
Thank you.
You're welcome. So in our postpartum period, which we talk about next week, so next week we'll talk about the postpartum, the intervention the nurse does during postpartum. And we're going to talk about a little bit of complications next week as well. So we assess in the postpartum period, mother's uterus is a priority, her bleeding. We assess her pain. We assess her interaction with the newborn. Is she bonding? We assess for depression, psychosis. So all of that will come next week. Okay. But the most important thing in that early postpartum is bleeding assessment. Okay. So remember, during the antepartum, we talked about the increase of plasma volume, increase of red blood cells, and increase of oxygen demands in the blood to be circulated through the placenta for the baby, right? During labor and delivery, that demand increases. Okay, the demand increases. So you're going to see an elevated heart rate, elevated cardiac output, and increased blood pressure during contractions. And during labor and delivery, you're going to see all those increases to effect a safe delivery, meeting the demands of the fetus. Mother's going to have an increased respiratory rate, hyperventilation, increased oxygen demand. So what are some of the symptoms of hyperventilation?
Increase PCO2.
Okay. What might she experience? What are her symptoms?
Rapid breathing.
What might she complain about?
Her heart rate,
Pardon?
the heart rate is gonna be increased. Feeling anxious.
Okay, okay.
She would complain she cannot catch her breath.
She also might have tingling and numbness, and numbness around her lips, tingling sensation, because she's hyperventilating. Okay. A tingling or a numbness. If you took a bunch of deep breaths very quickly over a short period of time, and then did it again, and then did it again, you're going to become hyperventilated, and you're going to have numbness and tingling around your mouth. Your level of oxygen is so high, and your CO2 levels have dropped, and that's what they experience. Okay, so some hyperventilation. So what's the answer to that? What would you have your client do if she was hyperventilating?
You can breathe into a brown paper bag.
Yeah, breathing in, rebreathing the air she's breathing, taking in. So a brown paper bag would be a good result to that. So if she says, I'm having trouble, give her a bag to breathe in. Okay. This is a great video. This explains to you uterine contraction, and it's very short. So I do want to take a minute for you to watch this, if it'll work. Hey. Uh-oh, where's my sound? Can you hear it? It should be where, anyway, she explains to you what a contraction is and what it's doing. Okay, and it's a really good video. So when you get a chance, if it doesn't work here, then you can find it on YouTube, because it gives you an opportunity to get it on YouTube. Okay, so I do want you to watch that when you get a chance. Okay, so once again, contractions in action. Dilating the cervix and effacing the cervix. So once again, this is a depiction of length of the cervical canal. When it effaces, it thins out. You can see in B, it's shorter, and then it's palpable, but it's fully effaced. And at E, she's completely dilated and completely effaced. So that's what contractions do. So, question. The second stage of labor begins with what and ends with what? Do you remember?
C.
Yes. So the second stage is the delivery of the baby. So when mom is completely dilated and effaced, she will deliver her baby, and it ends with the delivery of the baby. So non-pharmacological pain management, you need to look at some pictures in the book and be familiar with some of these concept or terminology. Effleurage is just usually during active labor, but not transition. This isn't going to work. It's just mom massaging her own belly. Okay. Aromatherapy, you probably know what that means. And then gate theory. Knowing what gate theory is. I don't know if I made a slide of gate theory or not. So gate theory basically, along the spinal cord, along the pathways, the sensory pathways, there are gates that open and close the nerves that are transmitted to the brain. If we stimulate some nerves around those sensory nerves, like a larger diameter nerve, larger nerve fiber, if we stimulate those, it decreases the pain sensory nerves travel to the brain. It kind of blocks sensation or it distracts it. So like a back massage, counter pressure, all of those things are based upon the gate theory. Okay, so look into that a little bit. We're running out of time here, so pain during labor, and this we talked at the beginning about the advantage of a pudendal and why we wouldn't do an epidural so late in pregnancy. And it's based on this theory that during the first stage of labor, which is labor, most of the pain is in the abdomen. As you can see in this depiction, early first stage, and then C is getting into the more advanced stage of, going into late transition. Okay, so visceral or cramping pain. So visceral pain is a deep pain, can be dull or sharp. Okay, so but it's a deep organ pain, and that's usually labor. During the second stage, as the baby is descending, it's more of a somatic pain sensation, somatic pain, because it's the floor of the perineum that has the greatest amount of pain. Okay, so the second stage is more somatic. Okay, a lot of rectal pressure, the desire to bear down, the Ferguson reflex. Okay, it's a reflexive action when someone has rectal pressure and they feel like they need to have a bowel movement. That's what's called a Ferguson reflex. And this is the same thing mom feels. She feels like she needs to push that baby out. Okay, so these are somatic pain levels. And usually the abdomen is not that much in pain in the late stages. So what do we use for that? Well, let's talk about what our choices are. We talked a little bit about opioid agonist and just opioids. And of course, this is meperidine, fentanyl, remifentanil, the real short-acting opioids. All of the opioids cross the placenta, okay? And usually remifentanil or sufentanil have to be infused with a pump. Okay. Nitrous oxide, Nubane or Nalbuphine is a opioid agonist antagonist. So it's a partial opioid. So this is something we would want to give to our clients who are on Suboxone or some kind methadone for abuse. They're in rehab therapy. We would want to give them a partial agonist. Okay. So other than opioids, not super commonly used in pregnancy or in labor, except at the very beginning, maybe a little opioid. But it's not as effective as an epidural. Nitrous oxide is being utilized now, and nurses have to go into training in order to administer nitrous oxide. The nice thing about nitrous is it's very short acting. You inhale it. There's no injection. Short acting, easy to give, patient controlled in a way. We teach the patient when to begin to inhale. Causes a little euphoria. you know, this is used in dentist office as well, or some kind of short procedure. It helps decrease a little anxiety, and it does have a pretty rapid onset. So it's great for contractions. So we want her to start breathing usually within 30 seconds before we expect another contraction. So she gets on top of it. And then as the contraction subsides, to stop breathing it. General anesthesia, usually done with an emergency. We usually don't like to put mothers asleep because it depresses the central nervous system, right? We have to breathe for them. Okay, we have to intubate them with general anesthesia. We have to. And then it also depresses the fetus. So it's not a good choice, but we sometimes have to do it. And then because of the effects on the central nervous system, it hinders her interaction with the delivery and the skin to skin time, because she has to recover from the anesthesia before she can really hold the baby. Okay, so that postpones that what we call golden hour after the babies. And because of the anesthesia, she's going to be more prone to fall asleep once she's awake. Okay, so if she's holding the baby and she's still somewhat sedated, even after an hour, you know, she could accidentally roll on the baby or drop the baby. There's also a risk for blood clots, deep vein thrombosis, if we use general anesthetics, because it slows the circulation down and causes pooling. And then we have the pudendal nerve block. So this is the best choice for that, the last part of stage 1 of labor during the transition phase. Once she's 8 centimeters dilated, using a pudendal block is very effective. It decreases the sensation to the pelvic floor muscles, the perineum, and the vagina, and the cervix. And it lasts for quite a while. And then the most common form of anesthesia is the epidural. Okay, so the epidural reduces sensation, not movement necessarily. And there's some disadvantages of an epidural as far as assessing. And we really need to go into the epidural a little bit because there's certain duties you have as a nurse. Okay, this is Bishop scores again about the inducibility. And then this is about induction, and I don't believe there's any questions on the exam about induction. Oxytocin. In that case study that I posted for this week, it tells you how to calculate oxytocin. It's a high alert drug. If we give too much of it, it can cause the uterus to contract too quickly. In other words, she's having more than 5 contractions in 10 minutes. That's the maximum. We don't want that. It doesn't allow the uterus to relax between a contraction if she's having 5 or more. Okay, and it's called uterine tachysystole. So it's a high alert drug. It's considered a uterotonic. Okay, what I might do is a short video on this for you. So the most common and potentially harmful maternal complication of epidural anesthesia is hypotension. So if you have a client admitted to the birthing suite and she's in early active labor, what is your priority nursing intervention? What do you think the answer is?
Is it A?
Yes. We need to auscultate the fetal heart tone. Yeah, we need to see because the rest of it can wait until we assess the condition of the fetus. And this last one is about epidurals. And I'm going to save this one, leave it like this, and I'll do a quick video about epidurals for you so we can save some time. Because we got to go through the fetal heart monitoring the last few minutes here. So this is a fetal heart monitor. And what do you think about this? What's your first thoughts about it? At the bottom, we have contractions occurring. At the top, we have the fetal heart rate. What do you think about this strip? And usually strips are in 10-minute strips. So let's just assume this 10 minutes, probably more than 10 minutes, but we're assuming they're 10 minutes.
My concern is I don't see any accelerations.
Okay, no accelerate, baby's heart rate up here at the top. There's no accelerations, definitely. What else?
For the first third of it, there's no reaction by the baby at all.
Right, she's had 4 contractions and the baby's not responding at all. We want to see a little bit of elevation of the heart rate during contractions. What else do you see?
The several decelerations would give me concern too.
Yeah, there's these dips up here means the baby's heart rate is dropping. And we always look at this and see what's going on with the mother. Okay, this baby's heart rate dropped after a contraction. That's what we call late deceleration, and that's not a good sign. Okay, in fact, they're all occurring after the contraction. So something's going on. The placenta is not being perfused. Okay, and the reason it's not being perfused is why? Why isn't blood flowing through the uterus adequately?
Should she be laying on a cord? She might be repositioned to see if there's any changes.
And the blood
Well,
pressure.
okay. Okay. We don't have that information though. What else could it be?
Her contractions are coming too fast.
Yes, there's too many contractions here. Five contraction maximum in a 10-minute period. Okay, so this is more than a 10. 1, 2, 3, 4, 5. Yeah. So, but still she's having more than 5. So her uterus is not able to relax and be filled up again with blood to provide for the placenta. So we're seeing decelerations in the baby's heart rate. Okay. Understanding, remember the first week we talked about, or at least last week, we talked about the importance of placental perfusion of blood from the mother's uterus, how important it was for a constant flow to provide the oxygen to the fetus. If the fetus doesn't get good flow, good oxygenated blood from the placenta, then the heart rate is going to drop. Okay, we call those decelerations. Okay, so we put our monitor on. Our TOCO transducer is measuring the uterine contractions. So it's a TOCO. TOCO, it means contraction. Okay, and then the ultrasound picks up the baby's heart rate. Here's a picture of internal monitoring. If we're not satisfied with the pictures on the outside, if we're having trouble picking up the heartbeat or the contractions are not registering well, or we really just need access to inside the uterus with a catheter, this is what we can do. We can do an intrauterine pressure catheter to pick up the pressure of the contractions. And then we're going to attach what we call a spiral electrode to pick up the heart rate. So the normals in a 10-minute interval, okay, the baseline, we want it to be between 110 and 160. We like to see accelerations. It just tells us the baby is adjusting to the environment. Okay. So greater than 10 more beats. So if the baby's baseline is 130, we'd like to see it bounce up to 140 every once in a while and stay there for 15 or 20 seconds. Okay. Deceleration means that usually means that the baby is not getting good blood flow and it drops the heart rate. If they're early, if they occur before a contraction or right at the peak of the contraction, they're harmless, okay? But if they're at the end of a contraction or between contractions, then we need to intervene, okay? Early means it's occurring as a contraction begins or at the peak of the contraction. Late means it's after the contraction or between contractions. So reassuring would mean that the baby has a heart rate between 110 and 160, has some accelerations, and no late decelerations. So here's a graph or a strip of fetal bradycardia. So what heart rate is that?
Less than 110.
It's about 100 right there. So it's 90, 100, 110, 120, 130, 40. So that's what, so it's at 100. So that's fetal bradycardia. We need to give mom some oxygen, turn her over on her side, try to improve oxygenation. It might be from opioids. You might see this with if you're given opioids. This is fetal tachycardia. This isn't a very good sign either because you've got two contractions that the baby's not responding to, and there's not much change in the heart rate. So this baby's tachying at 170. So variability means that example, if you're walking down the street and then a dog starts chasing you, you're running, right? Your heart rate goes up. If the baby is just relaxing between contractions and then a contraction comes and the baby starts moving around, the heart rate should go up. Okay, we want to see changes in the baby's heart rate. If we don't, then we're concerned about something else going on. So variability is just the changing of the baby's heart rate, the normal changes. Just like if I put a pulse oximeter on your finger and I would see your heart rate change from 70 to 78, 76, 82. It doesn't stay the same all the time because you're moving or you're changing your position. And the same thing with a baby. We want to see a moderate amount of variability. So this one here, 6 to 25 beats per minute changes. So you can see the one in the middle. You can see the triangles, the upstrokes. See, so it's a variable rate. This is a healthy, moderate variability. The baby, it looks like the baseline is about 150 and goes up to 160 and even 170, but it drops down. That's okay, as long as it doesn't stay up there. And then a marked variability is something we would have to look into as well. So we want moderate variability. A sinusoidal pattern means it's regular. This is a sign of hypoxia or severe anemia in the fetus from isoimmunization from ROGAM antibodies. So we would probably have to deliver this baby right away. So, question. A nurse observes on the monitor that the client is having 6 contractions in 10-minute time frame. How many contractions are considered acceptable within this time frame?
5.
Well, it says greater than. Which one of these acceptable?
Greater than 3.
Yeah. What would you do if she was having 10 contractions in 10 minutes?
Can you do less lateral? Like kind of
Yeah.
reposition her?
And if she's getting oxytocin, if we're giving her oxytocin, we need to turn it off. Okay, turn off the oxytocin. So here's early decelerations. Okay, so head compression. It's just when during the contraction, the head is being compressed. So we're not concerned because it's early in the contraction or at the peak of the contraction, and it ends as the contraction subsides. So those are early, they're harmless. So this is more example of an early deceleration. It mirrors the contraction. However, a late deceleration we're more concerned about because it means that the placenta is not getting perfused. Okay, so if you see a deceleration that starts at the peak of the contraction, a late onset, if it starts and continues after this contraction is beginning to decline, then you know the placenta is not being perfused adequately and the heart rate drops. So this is a late deceleration. Once again, turn off any oxytocin and reposition. Give her oxygen. Another picture of late decelerations. The baby's heart rate drops after the contraction. And then there's variable decelerations. Variable decelerations are shaped like a V. They're very abrupt. They occur anytime, whether there's a contraction or not. And this is the cord. The cord is being pinched or it's impinged so that blood flow doesn't go through it and the fetus doesn't get the oxygen. So there's different kinds. And so this is what we would do for a variable deceleration. Mom in the knee chest position. Okay, and you can see how that baby's dropped back down into the uterus and the cord is now free. Prolonged deceleration's a bad sign. So we're going to put it all together for you because most students don't understand. They feel overwhelmed. So I tell students every quarter, if you don't know, if you don't think you would recognize a late deceleration or an early deceleration, or you don't know what to do, memorize a veal chop. Okay, this is a tool to help you memorize so that you know how to respond. Okay, if you see variable decelerations, and that's your V in veal, your intervention would be to change position and turn off the oxytocin. The C tells you that the variable decelerations are caused by umbilical cord compression. Okay, the E in veal stands for early deceleration, and that's because the head is being compressed during contractions, and that's fine. The A is the accelerations, and they're okay. Okay, but the late decelerations as well as a variable are bad signs. It means that the baby's not getting the oxygenated blood that he needs. So the late decelerations, the L in veal, refers to P in chop, and it's the placenta that's not getting the oxygenation. So uteroplacental insufficiency. So memorize veal chop. You're not going to be required on the exams to identify a fetal strip. In fact, the HESI, there's no fetal strips. But you do need to know what your intervention would be. So fetal tachycardia is most common during which of the following situations? What do you think?
A.
Yeah, fever. If a mother has a fever, she usually has tachycardia. If she has a fever, so does the baby. The baby's going to be at the same temperature as a mother. Okay, so the baby's going to have fetal tachycardia. It correlates. And here's a game, electronic fetal game. I also gave you that website separately. Okay, so we went beyond our time. There was just a lot of stuff. So I went through that quickly. Okay, so it's important that you memorize field chop, be familiar with what a variable deceleration means. Okay, just know in the late know the veal chop. Okay, and we can go over these things again. My study session will be this coming Sunday at 7 p.m. on this Zoom. We'll be covering, we're going to go over case study, and then we're going to cover labor and delivery. Okay. Any questions? All those documents that I shared today are available to you in the announcements.
Were you going to show us how to submit our NCLEX?
The NCLEX, yeah. Let me. I'll keep recording. Those of you who already know how to do it, that's okay. Okay, so let me share my screen again and find the NCLEX questions. Oh, let's see here. Who's that Jen Bolton there? She's changed her looks. Who is that? Okay, just a second here. All right. Do you see the modules? We got to go to modules. Do you see the module? Do you see my screen?
Yes.
Okay. So going down to week 3 module, week 1, week 2, week 3. Sonder, so this takes us to the NCLEX questions. Click on that. It will go to the book. There we go. Continue. And so you're going to click 50 under the exam mode. All right. So the mode is going to be exam, and you're going to choose 50 questions. And then the category you want is content area. And then come over to the subcategory, it's maternity, and drop down, click antepartum and interpartum. And then you begin the session. Okay, so that's how you would do it. So I'm going to do 10, and because I want to show you how to submit. Okay, so we got 10 questions, and I'm just going to go through them real quick. I don't know what the answers are. I'm not reading them, but just to show you how to do this when you're done. Okay. Now I end and tally. And this is what comes up. Okay, so you scroll all the way down the bottom and you see today's date. You see I did exam mode, 10 questions completed. Click on it and it'll come up like this. And I need all of these pages, okay? So what you do is you hit print results, whether you have a computer or not. Print results, and it'll come up, and you'll have a choice in the destination. Look at the destination. Instead of printing or faxing, we're going to save it to a PDF, okay? And then you would decide where on your computer you want to put it. You can put it on your desktop, documents, but put it somewhere and then save it. Okay? So that when you come back to week 3, when you're done your questions and you've saved them, here we go. Saunders questions right here. This link, and then you're going to upload. This one maybe not, but it gives you an opportunity to upload. So you're going to go back and find that document, that PDF that you saved, and upload it. And it'll show up in your NCLEX questions, and nobody here has done any. Okay, it'll show up right here. Okay,
I'll be out in a minute. Hang on.
so that's how you do it. You have to save your questions as a PDF on your computer and then upload that PDF. No screenshots, no pictures of any kind, because I have to see all of the pages. I have to see what questions you chose. Okay. All right. That's it. Thank you for hanging on. And I will make a quick recording about epidurals since we didn't have time to go over that, and post it.
I got one question.
Yeah.
What are the chapters are we covering for the test again next week?
So it'll be weeks 1 through today. It was chapters 1 to 3, and then 6 to 10, and then 13 to 16.
Thank you.
Okay. Sure.
Thank you, bye.
Bye, Cassandra. Crystal, do you have a question you'd like to ask?
No, I'm good. I was in the middle of writing, so, but have a blessed night.
Yeah, it's good to see students writing things down, because some don't. They just kind of sit there and hope to remember everything. And you don't remember hardly anything of what you listen to. That's why it's important to write notes.
I didn't write a whole lot from last week down. So when we got that quiz this week, it's just kind of killed me on that. So
Yeah, that was a tough quiz. Yeah, that's usually what happens. Yeah. All right. You just let me know if you need anything, okay?
all right, I appreciate it. Thank you.
You're welcome.
Bye.